conference will now be recorded.
And so I'm gonna go ahead. I'm gonna turn the first item over to Jose and Saki. So go ahead, Jose. Why don't you kick it off, and then let Saki do her thing.
Right. Thank you, Bob. Next slide. Well, we have some issues that we would like to cover. First and foremost, and thank you so much for being part of this conference call. And on behalf of the National Center for Health and Public Housing, thank you so much for all your support. We are about to finalize this cycle, this 3-year cycle, and in July, July 1st is the first day for the next program cycle. So thank you for all the support, all the information that you provided, the advice and everything, you know. So we have been able to develop training and provide technical assistance to those health centers in or immediately accessible to public housing. Thank you so much for that. And also we really wish that everybody, we really hope that everybody is doing well, you know, and you are healthy during these difficult times. We are living new challenges, new public health issues. I don't remember anything like this, you know, at least. I mean, we've been discussing throughout history and books about the flu pandemic in the 1917 and then the plague in the medieval times. But that for our generation, I believe this is the first time that we are facing a pandemic like this one, and it's been affecting nations, continents, different races and ethnicities. So since everybody is susceptible to the virus, everybody can get it, and it seems that the virus is being affecting more vulnerable populations. So we are planning to cover some information that you have provided to HRSA on COVID-19, some of the challenges and best practices. We would like to hear from you about any other issues, and at the end, we would like to discuss a virtual option for a training activity and some learning collaboratives that we are planning to do for the next 3 years. Next slide. So just as an introduction, I mean, we heard about the COVID-19 on December 30th, 2019, when China reported the first cases here in the United States. The first cases were in the period from February 23rd to the 23rd, 14 cases of 19 were all travel related. And then first we heard about the community transmission from February 26th to February 28th. And since then, you have been working in your communities and you've been providing testing and been with your patients, addressing all the healthcare needs during the pandemic. So thank you so much for that. Thank you so much for being part of your community, for providing, you know, and sacrificing, making a big sacrifice, you know, to provide services during these moments or times that are very, very challenging. Next slide. So I'm going to stop for a moment. I'm going to turn it over to Saki. Saki has been working on the reports that health centers have been provided to HRSA, specifically on COVID-19, about the needs, the challenges, and all the information that you have provided. Saki has analyzed the public housing primary care data for you. So Saki, you can take it from here.
Thank you so much, Jose. So Thank you. So as you know, HRSA has been surveying health centers on COVID-related issues every week for the past couple of months, and we have developed, as Jose mentioned, a series of infographics that highlight those findings. Those infographics are available on our website, but I just wanted to quickly share some of that data with you. As a reminder, health centers are asked to report on their needs and their status every week. So these data points that I'm providing to you are just really point in time. They reflect what's going on for that specific week. And to keep in mind that there's so much variation between resources and capacity across PHPCs based on their location. So when you see these findings, sometimes the trends, for some metrics, the trends are clear, and sometimes there can be periods of lag in the data, and there also might just sometimes on some metrics, it might just look like fluctuations. So I'm going to be reporting just what PHPCs are saying, not all health centers. Next slide, please. So this first slide is on testing capacity. You can see on the top graph, it shows the percent of health centers with testing capacity in blue and the percent with drive-through or walk-up in orange. And as you can see, testing capacity has gradually increased over time. In April, around 85% reported that they were able to test for COVID, and on May 22nd, that number was 95%. And that is also reflected in this graph below, where you can see the number of patients that are being tested for COVID has increased pretty significantly, at least since May. And that's because test kits and supplies have become more readily available in some states. So this blue line represents the number tested every week in May. And you can see that there are more than 20,000 patients tested for COVID at PHPCs. And then this orange line below shows the number of patients that have tested positive. I do need to say that this graph is a little deceiving because it looks like COVID rates are decreasing over time, maybe partially because of that increase in testing. But next slide, please. But there is a glaring inequity in the distribution of these positive COVID-19 cases, particularly at PHPC. So this blue bar represents the total cases of COVID at PHPCs, regardless of racial or ethnic background. So all of the COVID cases. And although there are some fluctuations, you can see that rates have decreased at least since the highest point, which is the end of April. But that orange bar that's hiding behind it is showing the percent of racial and ethnic minorities that are testing positive for COVID. So every week that we have received racial and ethnic data, we can see higher rates among minorities, higher COVID rates among minorities. But in the last two rounds, more than 80% of the positive cases were racial and ethnic minorities. So why is that? Well, part of that can be explained by underreporting during those earlier weeks. So many health centers said that they just weren't able to report racial and ethnic background data, and it's possible that they've increased their ability to do so from the following weeks. And I think it's partially our job to figure out why those numbers are so high and what we can do to increase. Is it outreach? Is it education? Is it supplies? Is it coordination with other partners to address this issue? And I know this is a very sensitive time in the country. Racial injustice is really on the forefront of our minds, and this data only support that reality, unfortunately. And I think we all knew that would be the case, considering the challenges that our populations face. But the sheer magnitude of this inequity is quite disturbing. So I look forward to hearing from you, maybe in the discussion, on some of the strategies that you have engaged in to address inequity, any best practices that you have that could work on this issue. And just quickly for a comparison, just to put this in context, only 40% of patients at PHPCs are minorities, but 86%, at least for the last week of data, of the COVID cases were minorities. And this issue is also a little bit concerning because this is one of the few times where we see a real difference between how PHPCs are, the rates at PHPCs compared to just the rest of health centers. If you look at the data to all health centers from HRSA in the last couple of weeks, their rates for positive cases among racial and ethnic minorities was around in the 60s. So there's a 20 percentage point difference between all health centers and PHPCs. So there really are some unique challenges that PHPCs are facing and that we need to address. Next slide, please. So on top of all of the other challenges, right, including how COVID has affected health center staff. So the blue bars on this graph show the number of health center staff that are testing positive for COVID. Really hard to say what's going on here since there's so many fluctuations. The orange bar shows, or the orange line, sorry, shows the percent of staff that are unable to work because of site closures, COVID exposure, family obligations, all of those reasons. And it looks like while there has been a decline, there's still, it's a significant issue. Around 12% of the staff are still unable to work. And it's important for us to understand how health centers have been navigating that challenge, particularly as lessons learned that they can share with other health centers that are just starting to see new cases of COVID, or if and when a second wave of COVID hits in the fall. So next slide, please. So, and this next slide just shows how much COVID has affected patient visits. I know Jose will be getting into this later, but overall you can see that PHPCs are operating under much lower patient loads, and that has real implications for keeping the doors of the health centers open. One of the strategies that we have found health centers are really using telehealth to compensate. Around 56% of patient visits are done using telehealth now, which is of course much higher than pre-COVID. Next slide, please. I'm gonna end on one happy note, the happy story, and that is that PPE supply has really improved in many areas. While it does continue to be a real struggle at some health centers in some areas, overall PHPCs are reporting higher adequate supplies of masks, gowns, gloves, and goggles. And that's it for me, Jose. Passing it back to you. Next slide.
Thank you, Saki. Health centers have been reporting to primary care associations as well. And the last report that we got from HRSA in regards to supplies, personal equipment supplies, there are some areas where shortage remains, and other health centers have been reporting some issues. Well, they are concerned with the quality of the personal protective equipment. There have been some areas of improvement as well. PCAs are working with organizations just to get bulk orders of personal protective equipment, and there has been some improvements in the chain of supply. So it seems that even though in some regions the supply of personal protective equipment is still a challenge, at the same time, all the regions have been reporting some kind of improvements based on the PCA conversations or with the health centers. Next slide. So in regards to testing supplies, we know that in the beginning we had really big issues with the testing toolkits, and the challenges were basically timeliness and validity, and testing validity, and lack of supplies. And that was a big issue. Still, there are some concerns regarding the testing validity, specifically for those rapid testing. Those that have not been approved or they are not FDA approved, and those are taking like less than 5 minutes to give a result. It seems that there are some of them that are not very reliable, and one of the concerns is whether or not you should keep using this type of testing. However, at the same time, some of the health centers have been reporting better coordination, and that the availability in some areas is much better than where it was in the very beginning. Next slide. Now, the PCA report also mentions other challenges like budget cuts and how to follow, contact tracing and doing the contact tracing. And the other one from some of the areas, like I imagine San Diego or those areas where tourism is during this season is really high, that they're still concerned about whether or not this season is going to cause any impact on the number of positive cases. So that's another issue that was reported to the PCAs. Next slide. In regards to the change in the number of patient visits, some of the challenges reported to the PCAs are that patient visits are down significantly, that patients fear infection if they go to a health center. And the other one is in regards to workforce, there have been significant layoff, site closures, and furloughs. In regards to improvement, there has been, among all these challenges, some good news in regards to telehealth services, and telehealth has been a very useful tool for health centers. And in regards to developing infection control protocols, it seems that we are doing much better than in the very beginning. Next slide. Now, in regards to telehealth services, some of the challenges reported is that some patients do not have access to Wi-Fi, or they have lack of proper equipment, or they have issues because they are not they have some technology issues that do not understand the system, or they are not computer literate. So there have been some of the issues in regards to improvement. Telemedicine capacity, health center have been building telemedicine capacity, and there have been improvements in publicity, education, and experience. Next slide. Now, Saki mentioned minorities and racial and ethnic disparities. Health centers have been reporting that agricultural workers have been highly affected by COVID-19, as well as the minorities that Saki mentioned in the very beginning. Next slide. So there are a couple of priorities during the COVID-19, and this is something that federal organizations have been working on. One of the biggest concerns is the scheduling site visits and well child visits during the different time of the day. There has been some issues in regards to vaccination, and specifically for children. And remember that that is one of the biggest concerns, because we have other infectious diseases that are vaccine preventable, and if we need to address those issues. And the other one is how to reduce crowding in waiting rooms. So those are the main priorities that CDC and the other federal organizations are working on how to help health centers and other organizations on how to improve these issues. Next slide. In regards to priorities, same information. I mean, testing, infection control, testing equipment, air purification systems, vaccine, therapeutics, treatment, prevention, and those are the priorities. I'm going to stop for a moment here, because we've been providing some of the highlights that you have been reporting to HRSA and the PCAs, but we would like to hear from you. I mean, what challenges health centers are facing in your area, or what challenges your health center is facing, and what have you been doing to improve the services for the populations that you serve. So I'm going to stop and see whether we can get some feedback from the participants.
And while you guys are thinking about your responses, I just want to come. When we met as a group, a couple months back, everybody was I wouldn't say frantic, but they were exhausted and they were struggling with supply issues, with staff issues, getting testing kits, putting in place protocols, getting tents set up for triage. And keeping the COVID, patients, separate from the rest of the patients and so on. So I imagine, and just in discussions with different health centers over the last, few weeks or a couple of weeks, things seem to be better, but we're looking at kind of where you are now and also kind of thinking about the future because, it seems like COVID is going to be around for a while. So, Veronica or Zara or Eneris, if you'd like to chime in, please do.
This is Zara.
Veronica. Oh, go ahead.
Go right ahead, Veronica.
No, I was going to ask the question again because I joined late, right? Because were you asking what are our priorities or what are our challenges?
Yes.
I missed that.
Yes.
Challenges. I think just like Jose just said, it's about workflows. It's about having adequate staffing and make sure they're trained for contact tracing, because we were talking to Chicago Department of Public Aid and, soliciting some help from them, talking to them a couple of days ago about that. And I think it's how do you separate your clinic by having well visits separate from, sick visits, do some one set in the morning, another in the afternoon, or, we have it where we have two separate long hallways leading to exam rooms. So the providers and I were all brainstorming to see, now that our state is opening up again, how do we do this? How do we avoid the crowding? How do we change our workflows to make sure we get people in and out? Do we have less chairs in our waiting area just to make sure it's, we can't accommodate you, and wait in your car? And when we're ready for you, we'll call you. So it's the same like everyone else. And then now with the riots in some areas, some health centers have been damaged and closed. We have one of our health centers in one of the locations that they had some riots and buildings were damaged. Ours wasn't, but there's a lot of debris. And now we heard from staff this morning, because we've closed it for the past couple of days. So now staff, we're saying we're going to reopen that site on Thursday. Staff, I don't feel safe. I don't feel safe yet this week.
Wow.
To go back to that site. And then the other issue, the final issue I have is with, if something were to happen again, another bout of this pandemic, are we prepared to have, we rush into having some folks, we furlough some folks, we have some folks work from home doing telehealth, but do we have the right policies in place? What about workman's comp? What about all of that? So we're looking at those as well. And just this morning, our COO sent me some sample work from home, because we typically have not had our staff work from home except during this the riots. Mm-hmm. We've been fortunate. We've had folks do telehealth from the office, and we've been good. But now just this week, the riots, we've had to think differently. And we're catching up with the rest of folks who are now expert at working from home. What does that look like?
Yep.
Somebody is using. Hello?
En MedCentro proveemos estilos de vida saludables. Somos una organización sin fines de lucro que provee servicios de salud en Ponce, Peñuela o a la vía Villalba. En un momento le daremos más detalles.
Yeah, I think you may.
If someone put us on hold and don't, instead of mute.
They want to mute everybody.
Oh my God.
Además de nuestros servicios médicos, promovemos programas de actividad física como es el ciclismo. De esta forma, ofrecemos a nuestros pacientes opciones para mejorar su calidad de vida. En esta llamada le daremos más información.
I went ahead and just muted everybody, okay, right now. Dr. Leon, can you leave?
Yeah, I can.
Yeah.
Sure.
Okay.
All right. So next slide in the meantime, Fede. Sorry. But before we get to that, can you unmute all lines again just to make sure that we are good now? Yeah.
Sure.
Centro implementamos los últimos avances en la tecnología.
All right. Bob, I believe that you would like to discuss a couple of things here. We are going to unmute you now, Bob, and see whether you can address the other issues.
Okay, great. Okay, well, it seems to be working. I wanted to talk, I guess, about a couple of things. And the first thing is really the training symposium, and that's the virtual option. So Fide, maybe just go to the agenda slide number 2. There you go. Okay. So the training symposium. Okay. So as you all know, unfortunately, we were forced by the COVID-19 restrictions to cut or to cancel our conference. In our initial discussions a couple of months ago, most people were not much in favor of a virtual session, but I think now, given the uncertainty about what's going to happen with COVID in the course of the next few months, we are probably going to be forced to do a virtual conference. So we wanted to get your feedback first on doing it that way, and then next, you know, if somebody has any examples of a virtual conference that they've attended where there were certain features that they have liked, we'd be very interested in hearing about those, and then want to talk just real quickly about scheduling. So I guess the first issue is just everybody's feedback on actually doing a virtual conference. So I don't know if we could maybe hear from Zara and Veronica and Eners if she comes back.
Fide, you can unmute Zara to see if she has anything to say, and then Veronica and the rest of the participants.
Yeah, I think it's coming from Eners's phone. She must have put us on hold or something.
Yeah.
Zara, is it possible that you could unmute yourself? For some reason, I don't see your name here, so I can't.
Yeah, try to unmute everybody.
Hello.
There we go.
This is Zara. Can you hear me?
Yes.
Yeah, we can hear you, Zara.
Okay. Would you like me to go ahead and address the questions that Veronica did before we talk about the conference?
Yeah, I think so.
We can go back to that issue and then return to the virtual.
Okay. Like Veronica was saying, the riots have added now another level of challenge in our areas, as I described to you, Bob, and Jose before we started. And so we've been dealing with that this last week, and we don't know, you know, what's going to happen in the near future. And yes, some of the staff are very concerned. We've ramped up our security guards, especially in those areas that we hear from our law enforcement connections and our social justice groups, you know, what's planned in what area. So we're trying to be on top of that. In terms of COVID and the rate of our vulnerable populations, having positive results, they're so much higher, I think, than the general population, is alarming, but it also shouldn't be that surprising because, our vulnerable populations have faced a lot of health disparities for years, and stemming from adverse social determinants of health. So I think those are the root issues. And so every other plague or pandemic or any other crisis, of course, our vulnerable populations are going to be affected disproportionately. And that is a problem. But again, I think, as a society, we have to look at what those root causes are. And that's the whole social determinants issues, and has to do with social, injustice and so forth. But basically, this is a population that we're serving, and they all, it's like, look at the level of complexities and intersectionality between health and housing and economic opportunities and education. I mean, it just is very compounded, complex issue that I think needs to be addressed. In terms of the SQHC perspective, we were 50% down on our visits, and we ramped up our telemedicine, telehealth, telephonic visits. I think I reported on this last time. We never stopped serving the population. People were afraid to come in. We right away did the work, the screening, the flow, the well visits over here in one building, the sick visits over here. We called it cough and cold clinic. I think that we're concerned about the whole rate and the reimbursement and how we're going to be filing our reconciliation reports if our expenses are lower and or higher and the visits are lower than usual. We're also being very active with advocacy about telephonic capacity, telemedicine capacity, that we should be able to continue these visits even after COVID. It's been very successful with the substance use disorder, with behavioral health, mental health. We've seen a big increase in domestic violence and also depression, anxiety. So that's really important that we continue to ramp up those service modalities, and very high compliance rate from patients that are able to call in and get seen that way. We have reopened our dental. We were just doing emergency dental. Now we've reopened our regular general dentistry, and not at all of our sites, but we're in the process of doing that. Our ongoing concern is the PPE. Yes, because we are expecting like a lack of gowns. Working with the vendors, our CPCA, coalition, our local coalition as well, and the county and every other place we can find them. But yeah, that's the expectation, is that we're going to be running out of gowns. And yes, we're going to continue needing these PPEs moving on into the future because, God forbid there is a second wave or, whatever. We don't know how long we have to be utilizing this equipment. In terms of crowding in the waiting rooms, we have removed chairs and reformatted each area. We do have people waiting in their cars. We've also looked at, like Veronica was saying, the whole flow, the workflow. So looking and re-examining the role of our medical assistants in the whole process, and then looking at the number of screening questions that are, we usually have like 20 questions in the, when you're doing the vitals and the history and whatever, and how much of that could be pre-screened or done ahead of time. And actually, one health center I was speaking with here in San Diego has adopted a shorter list because the national procedures protocols from, I believe it is CMS, has said that we can adapt a shorter list during this crisis. We haven't done it, but but another clinic has. So I'm just throwing that out there. And let's see. I think that Another modality that's really helping us right now is our app. La Maestra came out with our own app, and it has the capacity there for people to answer the questions, for the COVID screening before they come in and take their temperature, outside the door and whatever. But they can go ahead and do that, send it in. So at least we have that, and we have it as part of their electronic medical record. And through that app, we are also able to deliver health education, reminders of visits, and, lots of cool stuff. And information that people need to know. In terms of the workman's comp policies, yes, we've started this. We're still liable under our workman's comp policy for the ergonomics for people working from home. So what we've done is, obviously we can't send teams of people into their homes because of, the infection concern and so forth, but virtual assessments of their workstation at home. And of course, that's going to lead to, oh, well, I need a different computer. I need a different this. I need a different that. And we don't have the money for that, to set everybody up long term. Those people that are going to continue working from home, we have to find some kind of solution with this in terms of funding. And the other thing here in the state of California is that, about, I want to say 3 weeks, a month ago, the governor, one of his issues that he created was that it is a presumption that if a employee does result with COVID, positive COVID test, it's presumed automatically that that employee got infected at their workplace. And that is unfortunate because all of the tracing that we've done on all of our employees that have tested positive have all come from external, outside, infection from their family, their husband's workplace, the daughter that was babysitting for somebody. I mean, we have it all documented, and it's really outrageous because that's going to raise the number of workman's comp claims. That's going to raise our policy, our money that we have to pay, and it's basically wrong. So that's another thing that that we're dealing with. And in California, that we had the May revisions briefly. Again, I don't know what all is going to pass, but one of the big issues facing our SQHCs out here is the whole 340B supplemental funding for the pharmaceutical medications for those people that are extremely low income. They can't afford their medications, and so that program is on the acting table, and so we're scrambling trying to find out what else to do. Otherwise, a lot of SQHCs in California are going to have to carve in to their rate, to their scope and rate, the pharmacy and dental. So that's something that is really going to be a problem because many health centers just won't be able to operate their pharmacies, and I don't know. So we're dealing with that. Lots of advocacy around that issue. In terms of the symposium, the training symposium and the conference, I think that's great. I've attended other virtual conferences. One that's coming up is the RISE Social Determinants of Health Conference, and that's going to be here in June, I think next week on the 10th. So that's a nationwide conference, and I think that they're expecting quite a bit of people to attend because, I mean, what else are we going to do? We know we can't go attend in person, so it's either that or we wait to have conferences for what, another year or after the next flu season. So I would be in full favor of going ahead and doing this conference.
Okay.
And Zara, you brought up a point, what else are we going to do? And I guess, and it's related to the conference and other training and technical assistance. And that is, are there particular topics that providers and other, health center care team members are going to attend? And are those that they're not going to attend? And are there particular times, like in the next few months, that are, you would say just, don't have it, this month or that month, because they're going to have other priorities or something during that period, whether it's, reporting or other conferences or any of that kind of stuff. Because we're sensitive to the fact that everybody's so busy, but we need to schedule something, and we're just trying to, find the best window available.
Well, I think I agree with that. But on the other hand, if we have the opportunity to hear from our colleagues across the nation, new ideas, creative ideas that we all need, because we have to be innovative, and I think that's why we're all surviving in this new, in this new environment. And what is it going to be like when we, reopen, and what units are other SQHCs reopening, and based on what? Like, I know that our mental health, behavioral health, all of those programs have just really grown during this crisis, and they'll continue to grow. But I think ideas would be very helpful, and to hear from others. Like, how do you imagine your SQHC? What's it going to look like, a year from now? What's it going to look like 6 months from now? How are you addressing these other issues? I think those are very pertinent points that I would make any time, any day, to listen to and to hear and to participate.
Okay.
Okay.
I totally agree, Zara, and you've covered all the other issues that I didn't mention. I think on the list of, I'm sorry, I'm all for virtual. I'm in with that, and it's just a matter of, when do we do that? Because we're having our PCA conference virtually in October.
Okay.
People are on the fence about that. Some people still, the people who've been, they've worked from home or whatever, they were anxious for a conference. They were looking forward to it. So they reluctantly gave in to the virtual, because I think we're going to be in the same position in October. And I think even if we're not, people are going to be afraid to do in person. I think any in-person conference, they're going to end up losing money, because who you expect, or even if they said they were going to show up, they're not going to show up in person.
Yep.
So I think if we add also, because telehealth is an obvious, but like something to the conference, we want to know more, like Zara was saying, about the work from home, because that's an extra liability now, and more about like HIPAA and stuff like that. And Zara, I'm interested to learn, maybe you mentioned this earlier, about the app. You said you're communicating to patients who are reporting their temperature through an app.
Yeah, where they fill out this little survey quickly, and that way.
So what's the app? What kind of app is it?
It's an app that our IT created about, it's it's our own app.
Oh, wow.
And
awesome.
And it's really cool because, it links you to the website. And of course, the big challenge for us is having, updating our information on all of our units as they're changing, right? So that's something that we just have to live with and grunt through, and that's on top of everything else we're doing. But the important functionality is that it allows, people to access, and we get the credit for the portal, for a certain percentage of our people, our patients accessing portal, and, all kinds of increasing access, because people have phones, so they could put the app on for free. They can access health education and so forth. So that's something that we're still developing, but right away we put on that survey for the COVID screening, and that was awesome.
Oh, that's good. Very good.
So that would be something, for example, that, I'm sure a lot of people would be interested to know, okay, well, how the hell did you do it? And we'll be happy to share, we're still in the process, but that's something that would be really interesting. And yes, you're totally right about virtual, and we have to get really up on all of this virtual communication and, connectivity and between
and more
our
about
programs.
More technology related.
Everything's going to be technology now. Even if COVID does die down and never come back, we've now passed that, that milestone where we all have to be super tech savvy.
Yep.
Yeah. And even if we go back now, because we've gone through months of, say, some organization having their employees work from home, in the future, if something were to happen, or say that employee is sick or something, and they said, I want to work from home, you can no longer tell them they cannot work from home. It's a new way of doing business. So
Exactly.
there's no going back from what we're doing right now. Whatever you're doing now, we have to learn how to do it better, how to incorporate more technology for smoother operation, communication, and all things virtual.
Right. That's so true. And the issue is that, you know, those employees that we know are going to stay home for the long term, and maybe we have whole departments that will continue to work remotely. That's why this whole workman's comp and the ergonomic and all that business is really important, as well as, you know, just a request, you know, look, I don't want to work on a laptop anymore. I want a hard, you know, desk computer and, you know, all this, and bring it. Well, that involves cabling. That involves having a line. That involves, you know, being virtually, you know, connected. And how much then in terms of HIPAA, like you said, are they going to leave the screen on and everybody's looking at patient charts? I mean, there's a lot, because it before it was like that with some specialty providers where they were able to virtually connect and do a lot of work from home and do their charting and stuff. But now we have a tremendous number more of people from home. So these are big issues, I think, that are going to face everybody. And I totally agree with you. We're not going back. We're going forward.
Yeah.
And here's one thing. How do you keep folks accountable working from home? Well, if you have an 8-hour workday, whether it's 4, 5, 6, 8 hours, how do you keep them accountable? How do you track them? So people are going to want to know that as well.
Yeah.
Yes, we have experimented with some of that in terms of productivity, and that requires the supervisors, managers, directors of those units to be constantly monitoring on a daily basis the productivity, because they can see how many, let's say if the person is doing call center or doing referrals or whatever, they can monitor the number of calls that were taken, made, whatever. And in fact, we just, you know, dismissed a couple of people because they just wouldn't take it seriously. They were at home and they just, they weren't doing the work. So, you know, those folks will not be able to transition to hold themselves accountable working from home. So that's why we decided to cut bait.
Right. So we're going to want to hear from the people who have done this successfully, have developed really good tracking mechanisms.
Okay.
Yep.
Have you guys heard anything back from the Bureau or from CMS regarding, you know, whether or not they're going to revise or permanently revise the telehealth rules and reimbursement rules, so that this is not just, you know, during the crisis, but, you know, is permanent?
I don't think that decision has been made yet. Zara, have you heard anything new?
I've heard and been part of legislative calls that's something that's really a top of the list for SQHCs. But you are right. That's still on the table. It's still being talked about. CMS doesn't know if they want to continue that and for certain kinds of visits. I mean, that's still big up in the air. And if they take that away, I don't know what we're going to do.
Yeah. Well,
Sarah and Veronica and all the other participants, from a training perspective, I mean, you've been giving us some really good ideas, you know. We've been working with HRSA. HRSA asked us to basically do an RFI on some of the activities that we would like to do on COVID, as you know, and we've been addressing, for instance, the psychological impact of COVID on healthcare workers. We've been doing some fact sheets for public housing residents in English and Spanish, addressing COVID and the hand washing and the other issue that is the public charge issue. Is there anything else that you would like, you know, or that you think your staff needs on training and technical assistance, either your clinical staff or non-clinical staff? I agree on the COVID situation. At least COVID is going to be with us until we develop a vaccine. The vaccine may be available by probably early next year, and yet there is no there is no final, you know, word on whether or not the vaccine will be effective enough, you know, to return to the normal life that we had before COVID-19. So I understand the COVID-19 issues that you have mentioned. Is there anything else regarding either behavioral health or diabetes or outreach or anything that you need from the finance perspective, or here, for instance, from CMS, now that you are talking about CMS, and anything that you may need that we have to incorporate in the training activities?
I think from our part, we've noticed that, social connectedness is extremely important among vulnerable populations. They already felt isolated. They already felt marginalized. And so with the social distancing, it's presented, an additional consequence of taking people back if they don't remain connected. Now, how do they remain connected? It's through the case managers. And I don't mean just case managers that manage your health. Like, did you make an appointment for the specialist, virtual, whatever visit? It's basically, how are you doing, and what else, are you experiencing? And can you, do you need to, or would you like to speak to somebody from our wellness unit, our mental health, behavioral health? It's basically keeping in touch with the populations and reassuring them that we're still there, we're still their supportive system, and hearing from them what it is that they are confronting right now, which is going to be impacting their diabetes, their asthma, all of the HEDIS indicators. So for me, if I could, I would deploy another 10 case managers that would be looking at the totality of these patients' wellness and well-being, and trying to connect them and keep track of them and encourage them and giving them the latest. I mean, that to me is huge. And that's something that our providers and our staff have all echoed, as well as our ethnic communities. And, we have 28 languages. We've got our cultural liaisons. So I'm hearing this like echoed throughout every service we offer on our circle of care. And that's really extremely important.
Excellent. Thank you, Zara.
And I agree.
And one other,
Go ahead, Zara.
I just wanted to say one other point about this testing business. We're having major issues in San Diego, probably nationwide, with the Abbott testing. It looked like some incredible, false negatives have come through. Number of false negatives. I think it was, I saw an article, it was like 85% of the negatives are wrong. And these are the tests that the hospitals are using, and the hospitals are only, they got the machines finally from Abbott, but yet because of the reagents and the lack of reagents and the, of course, problem with the reagents of giving these false negatives and false positives, they can only do 50 tests a day per hospital site. So it's like, where are we going with this? So it really demoralizes everybody. Like, why the hell even test? I mean, what's going to happen? Just so that the county can get their data, because we can't do anything for the people, and we don't even know if these results are right. It's very frustrating.
And in a similar way, or somewhat similar way, we're using the state or county lab, and they're overwhelmed. They're mixing up the names and birth dates, and so now people have to be retested. Everything is wrong. Not false test results, but the information. I don't know how. I think they're short-staffed, and all of a sudden, over the past few weeks, we're all experiencing them mixing everything up.
Wow.
So there's a lot of errors with having the test associated with the right person.
So
on top of every other issue with the testing, and when we were first doing the testing, it took 14 days to get the result back. Well, by then, who cares?
So Zara, to your point initially, so is the issue around the testing that you're experiencing having to do with the shortage of the reagents, or is it a problem with the test protocol itself, or?
Well, it's the whole test protocol. It's how the county rolled it out. They first told us to send everybody that we thought were suspicious. This was in the beginning, to the county. The county couldn't deal with them.
Yep.
The county would send them to the hospital. The hospital said, why are you sending them here? We feel like we're going to be swamped. Do not send people. They wouldn't even test them, nothing. Why? Because they didn't have the capacity to do the testing, and we see now why. And then, so we went to other forms of testing and, you know, working directly, sending the samples to Quest, to LabCorp, whatever. And then it took forever. And then, you know, like Veronica's saying, then they mix up the information. And basically from a clinical perspective, how you deal with that patient, you know, is going to be basically the same anyway, whether they test positive or not. The tracing is going to be different. Yeah, so we had opportunity to become a site for all testing in San Diego for the county. I said, no, forget it. This is just crazy. We're not going to do that. They were going to end with, you know, a bunch of crap results. Why are we even going to go there? But we are doing testing for the employees. The city employees going to go back to work. And we have to do two times the testing. So that's a smaller group to help those city workers go back to work. But oh my God, this has been a nightmare, and I don't see it really getting better. And those machines, Abbott wouldn't even sell us a machine. They said, no, you have to be a hospital. So when we described, look, San Diego does not have a county hospital. So people come here and to other health centers. Why aren't you selling us the machines? No, no, and no. So actually, I'm glad we didn't get one of their machines because the reagents are bad. So there you go.
Oh my God. Okay. We're about to run out of time, but can you guys hang in for another 10 minutes or so?
Sure.
Yes, I was checking my, I think I have a 2 o'clock, but let me see if we're still having it, but yes.
Okay, great. Jose, is there anything else you want to ask relative to COVID, or do you think we're pretty good there?
No, I believe that we're good.
Okay.
We have received feedback and very useful information, so I believe that we can move on.
Okay, great. And the feedback on the training symposium is very good. I just want to add that, you know, we're going to be checking out a couple of, you know, virtuals in the next, you know, month or so, just to see if we can find some, you know, promising practices and all that kind of stuff. If anybody sees anything that they really like relative to a virtual conference, and particularly something that that facilitates you know, networking and that kind of stuff, because I think that's the part we're kind of struggling with. And, you know, initially when we asked about it, people didn't want to, you know, really weren't keen on the virtual, because they of course were hoping it was going to, that code was going to end much more quickly, and they wanted to experience the face-to-face interaction and all the stuff that goes with a conference. But so we'd like to see if we can in some way you know, provide that opportunity for folks. And I know that they have the Zoom, you know, Zoom rooms and breakout rooms and all that kind of thing. But if somebody sees something that they really like or don't like, you know, please just shoot an email, because that would be really helpful. The other item on the agenda is the third item, which is learning collaboratives and letters of commitment, and it's just a very basic issue, and it kind of goes to part of the discussion we just had about the training symposium. And that is that everybody is just so bloody busy. You know, when we're doing learning collaboratives now, we have to assure that we get, you know, commitment from the collaboratives, and we have to, you know, next year have at least 10 health centers for each collaborative. So, and as part of that, what we thought about doing is, you know, asking for letters of commitment, you know, from the health centers that participate, you know, nothing elaborate, but just to say that, you know, they agree to attend the learning collaborative sessions and that they'll participate. So I guess I'm just throwing that out to you guys just to see, does that work for you? And do you have any suggestions about that or any concerns?
I think that works for me. I think that's fine. I would add a suggestion about the conference. If you could have some polling mechanism so that we could see how many health centers are really, you know, affected by a certain, you know, factor out there, or like how many would be interested in, you know, further training or virtual sessions on certain topics, and in what order, like what priority. I think that would be extremely helpful from a nationwide perspective.
Okay,
That's a great
I
idea.
agree. Yeah.
sounds great. And another, issue kind of tied to that, and also tied to the issue of just, training and technical assistance priorities. I'm curious because we asked this question a couple of months ago, and I'm just curious to see how much collaboration there's been between the, you guys at the health centers and the housing agencies that you work with in your towns. During the COVID period or on anything else?
Us, we're not working directly with the housing authority because they recently, I think a few months ago, got a new CEO. But we're working with the local advisory council. We're working with the management folks, the management company, it's called East Lake Management, and we're working with all the organizations in the community. We have an excellent outreach team that plan activities. They're doing a lot of virtual, and they're just working collaboratively with everyone, whether it's around the food insecurity and whatever else, because we have no grocery store, so the food is a big deal.
Yep. Zara, anything on your side?
Yeah, we also work with our Affordable Housing Commission, and we had a great track going before COVID, and so they've been relatively quiet. But as Veronica pointed out, I think our biggest strength is our outreach into the communities that we serve, and continuing to have those outreach workers, cultural liaisons, and actually do some, not just telephonic, but people still come in for their eligibility questions, for their social services. Our food pantry has tripled in size. We are also, launched this hot meal program where people can drive through. We distribute 250 bags of 2 meals in the bag, hot meals in the bag. And that's, of course, in response to our schools that since their kids aren't going to school, they're not getting enough nutrition. And yes, our areas, our clinic areas are all located in food deserts. And on top of that, we've had grocery stores that have actually closed down because of the riots and because they're fearful. So that's even putting more of a stress on us. We work with Feeding America, Food Bank, and and we just keep trying to write grants to get more and more food in. It's a real effort.
Okay, that's very helpful. And relative to that, Envision Centers is something we've talked to you guys about, and that's, they're trying to, self-sufficiency through health and wellness, economic empowerment, educational advancement, and character and leadership. Obviously we're focused on the health and wellness piece primarily, though we're also focused on economic, empowerment for folks. But relative to that, they were very stopped and started. They've picked up the pace. They've gone now from 16 to 42 Envision sites nationally. They're trying to get to 100. We're going to be doing a session with health centers and housing agencies, a webinar session in Regions 3 and Region 6 of HUD. And that's basically, Region 3 is from Pennsylvania to Virginia, and Region 6 is the Southwest, so it's Texas, Oklahoma, Arizona. I don't know if it's Arizona, actually. Maybe it's New Mexico, Louisiana, and out in that neighborhood. And I guess my question for you guys is, now I know that, Zara, you guys have had some experience with Envision Centers, and I don't know if you have really, Veronica, at this point. But in terms of the partnership piece, and this is relative to Envision Centers and in general, is there anything, is there any tips or any questions or any suggestions relative to facilitating that? Because we're seeing in some of our sites kind of a fall off in the relationship with the health centers, and some of it's due to changes in public housing, and some of it's just due to changes in staffing and organizations. But as I said, in 3 weeks, we're going to be doing a session with Region 3 and Region 6 health centers and housing agencies and Envision Centers. And I'm just looking for any thoughts you might have as to how to make that a better experience and how to get the health centers interested, because honestly, the health centers have been so busy dealing with COVID that obviously that this has not probably been at the top of their list. So any thoughts there?
I would say good luck.
Yeah.
When you said you were planning that meeting, I was going to say to you, you got to plan one in Illinois, because we haven't been, I know, we haven't been in touch with, directly with folks at CHA. They have not been reaching out to us, and that's disappointing. I thought during the crisis, during the pandemic, they would be trying to work more with us. Instead, we are the ones that are like, hey, and push it almost like they're nowhere. I'm not sure how they're dealing with other SQHCs since most of the public housing have been demolished in Illinois, but I would say good luck. And people have higher priority right now, but still, those in Virginia, those folks that you're meeting with in Region 3, do they still have a lot of active
Yes.
Public housing?
Yeah, they do. Yeah.
So then,
because you're talking about Philadelphia and some southern Virginia areas, and there's some in Delaware as well, and then in Texas, we've got some in some of the bigger cities there as well. And
as long as you're focusing around the care, and especially this should be a really opportune time in dealing with the pandemic. I think people will be interested. People will want to talk, but we don't have in Illinois. Nothing's going on. Not for me, at least. We're on our own.
Your Envision Center is actually led not by the CHA, but by a nonprofit organization in Chicago, and I can't remember the name offhand. In partnership with CHA, but the CHA is not the lead in Chicago, which is maybe part of the problem. I'm not really sure. But again, so is there any aspect of Envision or any of the stuff that, or just partnering in general, that would allow us to kind of get the health centers, attention? Any thoughts? Yeah.
Bob, I have a thought. When you're asking maybe or polling the health centers about their participation or involvement with Envision centers, public housing, subsidized housing, affordable housing, all that, I would also include if they're participating in any health home program brings in manage. Bring that in, because like we are really doing great on that. But that's a kind of parallel program, and I think by bringing those programs nationwide in that involve the managed care plans that have put money towards it and received federal funding to do exactly the health home model, I think that would be important in gathering your data.
When you say health homes, are you talking about healthy homes as in HUD, or are you talking about patient-centered medical home kind of thing, or?
No, the one that was through HUD that then became health homes, whole person care initiative, and then it depended if your county was going to be part of it, and then it went to the health plan. So that's something I would look into.
Okay, that's a great tip. Yep, I appreciate it. Thanks to both you guys for that. That's terrific. And then Jose, anything else? Because we're just about out.
No, Bob. We have already addressed the issues and TTA priorities, so that's all on my end.
Okay. All right. Well, thanks an awful lot, guys. This has been very helpful, and it's great to talk to you. And it sounds like things are at least a little better than they were 2 months ago. So we're happy about that, at least. But I'm sorry to hear that the protests have caused some complications for you guys. I hope everything's okay out there.
Thank you very much.
Thank you. It caused a little bit of setback, but I think we'll be okay.
Yeah.
I do too. Hopefully before the elections, we won't see another big round of these protests, but we should be anticipating that. I just wanted to ask a question. I thought I heard you say that this is the last meeting of our advocacy, our group.
For this year.
Is that what I heard, or for
It's
this
just
year?
for the program year, Zara.
Okay.
Yeah, because it's June, and the program year ends June 30, and the cycle starts up July 1.
Okay. Thank you for the clarification.
Okay, sorry about that.
Thank you, guys.
All right, take
Okay,
care.
thank you. Good luck. Good luck,
Bye-bye.
everybody. Bye-bye.
Bye-bye.